inviting me from Chandigarh, all the way from Chandigarh. Really honored and glad that Chennai, I'm very happy. I want to kind of thank the whole team. I want to respected chairpersons. So I'll focus on anatomical planes and dissection strategies for expanded introduction approaches. Okay, before that, I would like to welcome you all for the Neuroendoscopy during March 2025. So I humbly request each one of you to visit the city beautiful Chandigarh, and there are beautiful hill stations nearby. So we'll be glad to host you. You can send a mail or message to me. Shankar has beautifully explained how to plan the skull-based approaches for various lesions and how to plan. And Dr. Rupesh will be talking on the strategies for tribal lesions. So I will focus on how to design strategies in the intracranial tumors. This is one picture from Yesagil's book, which is a classic. Um, Here it talks about the different planes which we have to be aware when we are planning and operating through Indonesian approach. Basically, Yesagil showed this picture in the upside down manner. For the transcranial approach, I have just tilted it. As you see, this is the pituitary tumor. Pituitary tumor is extradural tumor. So you have the dura, diaphragma cell A, and then arachnoid, two layers of arachnoid, beyond which all the subarachnoid vessels are there. So as long as the tumor is in this plane, like simple pituitary tumors and small chordomas, they are extradural. So that if the configuration of the tumor is smooth, how much ever large they are, you can dissect them safely out of the dura without any problem. So you can go around or you can do internal decompression and then go around the tumor. But this is a case of meningioma in which the tumor is intradural but extra-arachnoidal. As you see, it is like in the previous video by Dr. Shankar, in which Dr. Rupesh was operating, how the tumor was intradural but extra-arachnoidal. Here, you have to remain in the right plane. That means extra-arachnoidal plane. You should not violate the arachnoid plane because then only complications will happen because all the blood vessels are in the subarachnoid plane. So now we have tumors like here craniopharyngioma, they are within the arachnoid layer. So you go through the subarachnoid space. Sometimes the vessels are adjacent, superior, depending upon the type of craniopharyngioma. And so these tumors have to be kind of operated in a different manner. So the key is to understand the plane and being in the right plane. It makes a huge difference. For example, in this, how much ever large tumor is, if you are kind of whatever happens, you cannot kind of injure the blood vessels. But here you have to be careful because the tumor can go in between the blood vessels. The blood vessels may be on the side. So this is very vital to understand. This is the sagittal view. This is from Seeger. As you see, the pituitary tumors are here, and always there is a hole in the diaphragm. So sometimes the tumor is giant, the diaphragm is thinned out, so you see arachnoid then. But always, if the tumor configuration is globular, smooth like a ball, it will always be extra arachnoidal. In small tumors, it will be extradural also, so it is relatively easy. In meningiomas, they like tuberculum cell meningiomas, they occupy this area. So here you go anterior to the pituitary like transtuberculum, and still they are extra arachnoidal, so you remain in the extra arachnoidal plane. Craniopharyngiomas arise from here. It can be from the lower part, middle part, or upper part. So this is, and they very rarely invade the posterior retroclavial area. This is the lilicus membrane. So most of the time in simple tumors they remain in this plane, but complex tumors I will show they will be in the retroclavial area also. In cavernous sinus, sometimes the sinus behaves like a single cavity, sometimes it behaves like a multi-cavity with lots of septations. So tumors, sometimes they invade in a globular manner into cavernous sinus, sometimes they invade into all these pockets. So each one has to be tackled differently. Grade 3B and grade 4, they are the most complex type of cavernous sinus invasions. All other can be, you can be conservative. For meningiomas, the size is not the single most important factor, but the plane and the lateral dural tail and the anterior dural tail. Basically, meningiomas we should never go as if they will always be soft. If we cannot go around the tumor, we should not go through intranasal approach, because some tumors they will be very firm and it will be very kind of difficult to get around. So first we do internal decompression nicely and then detach the tumor all around so that it will be loose. Dissection is very important, that we don't pull, as it has been pointed out, that no pulling should be there. Dissection and delivery is the key. Here we are seeing the A1. This is a little large meningioma. So we have to be careful, do circumferential dissection, gradually go around. Here we are seeing the ACOM complex. ACOM complex is more difficult to handle than ICA. So, because any injury will be devastating and fatal, you cannot control. So you have to take time to dissect all around so that the tumor itself falls and you don't have to pull at all. So all the both A1 complex and ACOM, then gently dissecting the vessel away from the tumor with its perforators, and then like a baby being delivered, you can take it out, and the dural tail has to be coagulated and then it is closed. So this is the post-operative view. So, and like these are different types of meningiomas. This is a middle clinoid meningioma. And so sometimes the tumor may be going lateral to the ICA, but still you can roll them gently. This is a diaphragma cell meningioma. This is another diaphragma cell meningiomas. So, and sometimes the dural tail, if it is very much lateral, you have to be careful because you cannot remove tumor from here. We have left a bit of tumor here. So these are the tumors you can choose to do transcranial approach. For craniopharyngiomas, the approach is depending upon what is its relation with respect to the infundibulum. So in pre-infundibular type, you can preserve the stalk, and again the tumor we should try to dissect more. 90% of the surgery is dissection, and dissection can be both blunt and sharp depending upon the plane. And here the tumor is stuck to the undersurface of the optic pathway, so we use both blunt and sharp dissection to dissect it away from the optic pathway. As you can see, you preserve all the perforators, and we always use angled endoscopes to turn around and see. This is the carotid, ACOM complex, this is the stalk. So by turning the angled endoscope, you get a panoramic visualization, which is the key for how it is superior to microscopic surgery. But anything which is close to the ACOM complex, especially when it is calcified, you have to be careful. You may choose to leave behind the tumor. And sometimes children, you have to remain within the cavity if you don't want, because this is a conical type of sphenoid sinus. It's a relative contraindication, but still you can go and remain within the cavity and remove this also. So in sometimes giant third ventricular cranio, as you see the stop, the tumor is above that. It is occupying the third ventricle. The plane is relatively good in this, as I have already told, because attachment is only in the third ventricular floor. Once you dissect here, the roof, everything it is loose. So you can easily dissect it, and then the tumor can be delivered and preserving the stalk. Stalk is posterior here. So this is the post-operative scan. These are other tumors. Sometimes the tumor is occupying the posterior fossa also. But in small children, you have to be conservative. and you can leave behind the retroinfundibular part and give radiotherapy. But in adults, you can be aggressive, and these are the transinfundibular type of craniopharyngiomas. If you can resect them totally, you can choose to sacrifice the stalk, especially in adults. Sometimes the tumor goes laterally till the Sylvian fissure, but if you can get hold of the capsule around, you can dissect and dissect them totally. So these are some of the tumors. Solid portion has to be removed. The cystic portion you have to be careful because they may be attached to blood vessels in the subarachnoid space, and you can choose to leave behind a little bit of capsule and give radiotherapy. But if you can go around, gross total resection is always better in the long run. And these and sometimes pituitary tumors, they have subarachnoid invasion. As you see, they are not globular. They have entered the subarachnoid space. These are the most difficult of tumors, even more difficult than meningiomas and craniopharyngiomas, because all the perforators will be very close. So you have to take a calculated decision of how much to remove. Too much if you remove, it will cause post-operative apoplexy, and you have to do a transcranial approach in the same setting. So you can leave only less than 25 to 30% of the tumor. Too much of the tumor you should not leave behind to avoid apoplexy. The way the shape looks, you will tell that these are probably invasive tumors, and they may be close to the vessels. As you see, this is the ICA bifurcation, how this globule is going around the ICA bifurcation. So understanding this becomes very vital to handle them, because all the perforators, lenticulostriate arteries are there here. And sometimes the tumor is small, but you see they are very close to the ACOM. These are invasive tumors. So this is a case of acromegaly. So remission becomes difficult. So in cavernous sinus invasion, I will not show the all videos. This is the carotid artery, posterior genu, and this is the horizontal segment. So basically this cavernous sinus invasion, it is occupying the whole of cavernous sinus without any kind of loculation. This is relatively easy. This is the roof of the cavernous sinus, and how at the end we can see the whole cavernous sinus with the sixth nerve here. And sometimes the cavernous sinus invasion is having kind of like in this one we have to do anterior-inferior approach. It is in a totally, first we have removed the cellular portion, and then we have to enter the cavernous sinus portion. This is a case of acromegaly. This is the post-operative. The lateral part is difficult to remove. We choose to give gamma knife after maximal safe surgical resection. Giant tumors, first you remove the middle portion, then cavernous sinus portion, then you go into the supracellular portion. Otherwise, the diaphragm will descend and it will interfere with your cavernous sinus extended. As you see, this is a gross total excision for cavernous sinus invasion, and these are some of the other tumors in which both there is cavernous sinus invasion as well as subarachnoid invasion. So the subarachnoid invasion is the most difficult, as I have already pointed out. Sometimes you leave. This is the grade 4 cavernous sinus invasion. You can give gamma knife. And in giant tumors also, sometimes if you can leave behind a little bit of tumor. But in these tumors, these are the most simplest one. Though the size is huge, you can go around and then remove them totally. Infradiaphragmatic cranio is simple, similar to pituitary, but most of them they will have pituitary hypofunction at the end of surgery. Hypothalamic gliomas are a different ballgame altogether. You have to just take biopsy and then give radiotherapy. You should not be aggressive in these tumors. So this is one thing you have to be very conservative. And in meningiomas, when it is going lateral dural tail, you cannot do endonasal approach, and you have to choose to do a transcranial approach. So for most cranio, giant pituitary and select plenum meningiomas and tuberculum, the gross total resection is feasible. Thank you.
Thank you, Dr. Mukherjee. In this presentation, we had all of the talks. I think now we'll go for the inauguration. So I think that is already there. We'll have the third lecture after the inauguration. Thank you. We'll be starting the inaugural function shortly. Our chief guest and guest of honor has already arrived.
We are going to start the inaugural function. I welcome our respected CME madam and DGP sir for the inaugural function. I request President Tamilnadu Association of Neurological Surgeons, Dr. Arun Kumar, to come for the dais, and President CNA, Chennai Neurosurgeon Association, to come for the dais. We welcome Medical Council Observer, Dr. Sushila madam, for this program. We are starting the program with Tamil Thai World.
நீராறும் கடலொடுத்த நிலமடந்த கேளொழுகும் சீராறும் வதனமென திகழ்வரத கண்டமிது தெக்கணமும் மதிசிறந்த திராவிடமிழ் திருநாளும் தக்க சிறு பிறை முதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அடைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிலமை திறம்பியந்து செயமறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Now I would like to request Professor M.Kodeeswaran sir to kindly deliver a welcome address.
I heartily welcome our Director of Medical Education, Madam, and guest of honor, DGP Sir, SYLENDRA Sir, and President, Secretary, Office Bearers of Tamilnadu Association of Neurological Surgeons, President, Office Bearers of Tamilnadu Chennai Neurosurgery Association, and Secretary, Skull-Based Society of India, Dr. Rupesh, and representative of Neuroendoscopic Society, Dr. Dandapani, and senior neurosurgeons, professors, HODs of departments of KMC, Medical Superintendent, Deputy Superintendent, RM of KMC. I invite all staff nurses, administrative staff, and all supporting staff for this program. I welcome all faculty members, chairpersons, and delegates for participating in this Cadaver workshop. Last but not the least, I would like to welcome Call Stores India Private Limited, Medtronics India Private Limited, East West Pharma, Cleveland Pharma, Celagenics Pharma, and Gladstone Pharma for supporting this event. Now, we are going to give a short presentation about our Department of Neurosurgery, Kilpauk Medical College. Department of Neurosurgery, Kilpauk Medical College was started in 2008. Next slide. It's a short history. Till 2021, only one professor was there. No beds were allotted to Department of Neurosurgery. Almost all trauma patients being referred to MMC, and remaining few cases were managed under Department of General Surgery with postgraduates of General Surgery. In May 2021, after joining myself, Mr. Yuvaraj joined as ward manager. In September 2021, two assistant professors joined after completing MCH from Madras Medical College, Dr. Arvind Kumar Tyagi and Dr. Mayin Kamal Goswami. I want to congratulate these two doctors because they are doing alternate day duties for the past 14 months without any hesitation. They are working like machines. So I would like to congratulate them at this time. Next, Department of Neurosurgery KMC is a baby of our Dean DME Madam. We got all unconditional support in all aspects. From September 2021, we stopped referring all neurosurgical patients from KMC and we started operating emergency surgery in emergency OT Thai, and Madam allotted 14 general beds and 2 HTU beds. Then we started running with 100% occupancy. Then we had a lot of difficulties to get operation theatre for neurosurgical patients. Then with the support of DME and professors of anesthesia, we established an exclusive operation theatre 24/7 from April 2022. During morning time, we used to operate elective and emergency surgeries. In the afternoon, we operate emergency surgeries. Mr. Soundra Pushpam, OT in-charge staff nurse, helped to establish 24 hours OT service in KMC for neurosurgery department. We recruited 2 OT technicians, Nandini and Praveen, covering 24 hours day and night for the past 10 months to support our duty neurosurgeons. And ward staffs Agalya, Jayasudha, Dilli, Nirmala, Sudha, Sajita and Ashna are supporting to take care of our post-op patients. In July 2022, we applied for MCH neurosurgery PG seat. With the unimaginable support of DME Madam, we represent to government, got all Tamilnadu government approvals with a short span of time. We are awaiting for NMC inspection. We received Independence Day Award from Chennai Collector for Neurosurgical Service in KMC. In May 2021, we started Deceased Donor Organ Transplant Program. This was started first time in KMC in the 6 years history. With the support of Department of Anesthesia, Thai, Medicine, Neurology and Admin team, we completed 30 certifications and harvested 7 donors till date. The donors donated 10 kidneys, 4 liver, 3 lungs, 3 heart valves and 6 skin and cornea 7. We have made a record of harvesting a donor of 80 years. We donated liver from that donor. It was a history in transplant history. Few news clippings. Our entire team got an award from Honorable Health Minister for initiating this organ donation program in KMC. Slowly we increased our bed capacity to 36 beds, 30 ward beds and 6 ICU beds, and we established a bed store ward with 10 beds for chronically ill bedridden patients. Now we are running with 100% occupancy of all beds. With the support of DME Madam, we got allotment of 60 beds in the new upcoming building JICA project. This is our surgical statistics. We operated 248 surgeries. Among them, 92 were elective and 156 were emergency. We have presented our initiation protocol in the National Neurosurgery Conference for this organ donation program in December 2022. And we have initiated 3 research projects in traumatic brain and spinal cord injury after ethical committee approval. It's another novel initiative. We have started Neurosurgery Academy Today we are going to inaugurate this program. We are planning to train new generation of young neurosurgeons and endeavor to conduct CMEs for upgrading our existing knowledge. So I request you to support this event from all group of neurosurgeons. Few rare surgeries in Department of Neurosurgery in KMC. We did first programmable lumbopetal shunt in Tamilnadu Government Hospital for unmarried young girl with threatening vision loss. We did first balloon kyphoplasty as a daycare procedure for a spine fracture in Tamilnadu Government Hospital. We are doing regularly percutaneous retroglycerin glycerol rhizotomy as a daycare procedure for recurrent trigeminal neuralgia. I am appreciating the unconditional support of admin team, Professor Aisha Shagin, Professor Anita, Dr. Vani, Professor Ratna Manjushri, and JOs. And appreciating unconditional support from all HODs of other departments, Professor Shanthi Madam, Murugan Sir, Vijay Shankar Sir, Pandi Selvan Sir, Devi Vinal Madam, Tirunakar Sir, Velusamy Sir, Muthuchitra Madam, and matron and staff team. This is our small team, Department of Neurosurgery, KMC. Thank you all for your attention.
Thank you, sir, for a welcome address. This will be followed by introduction of today's chief guest, AV man, by our respected M.Kodeeswaran sir.
அனைவருக்கும் வணக்கம். இது எனது நரம்பியல் அறுவை சிகிச்சை துறை பயணத்தில் இந்த மறக்க முடியாத நாள். தமிழக அரசின் 2 மிகச்சிறந்த ஆளுமைகள், மிகவும் எளிமையானவர்கள் இருவரை வைத்து இந்த விழாவை நடத்துவதில் எனது துறை மிகவும் பெருமை அடைகிறது. முதலில் மேடம் சாந்தி மலர் அவர்கள், மருத்துவக் கல்வித்துறை இயக்குனர், மிகவும் எளிமையானவர், தனது பணியை செவ்வனே செய்யக்கூடியவர், தமிழக அவசர சிகிச்சை துறையை மிகவும் சிறப்பாக மாற்றியவர், அவரது தலைமையில் என்னால் சிறப்பாக வேலை செய்ய முடியும் என்று நிரூபித்தவர், நியாயமான மக்களுக்கு தேவையான கோரிக்கைகளை காலதாமதமின்றி செயல்படுத்துபவர். அவரது தலைமையில் அரசு கீழ்ப்பாக்கம் மருத்துவக் கல்லூரி மிகவும் சிறப்பான வளர்ச்சியை கண்டது. மேலும் எனது துறை அளவு கடந்த வளர்ச்சியை கண்டது. Thank you, madam, for coming as chief guest. Madam has joined as assistant professor, Department of Anesthesia in 1994, associate professor in 1999, worked as professor in various medical colleges. Madam has promoted as Dean, Omandur Estate in 2014. Madam has worked as Dean in various medical colleges. Madam has promoted DME Officer on Special Duty in 2021. Since 2021, Madam has become Dean KMC, continuing till date. Madam was promoted as Director of Medical Education, Tamilnadu in November 2022. We thank you, ma'am, for consenting to be the chief guest for this program.
Thank you, sir. Also introduction. Now I request M.Kodeeswaran sir again to kindly introduce our guest of honor, DTP sir.
மருத்துவர் திரு சைலேந்திர பாபு ஐபிஎஸ் சார், அறிமுகம் தேவையில்லாத மிகவும் பிரபலமான நபர் தமிழகத்திலே. மிகவும் எளிமையான, கண்டிப்பான, மக்களோடு மக்களாக இணைந்து பழகக்கூடிய தமிழகத்தின் மிக உயர்ந்த பதவி வகிக்கும் காவல்துறை அதிகாரி. நான் 1992ஆம் ஆண்டு சிறுவனாக இருந்த பொழுது 11ஆம் வகுப்பு திண்டுக்கல் மாவட்டத்தில் சார் எஸ்பியா பணியாற்றிட்டு இருந்தாங்க. ஒரு ஸ்பெஷாலிட்டி என்ன அப்படின்னு சொன்னா, மருத்துவத்துறை மீது தீராத காதல் கொண்டவர், தீராத அன்பு கொண்டவர். யூஸ்வலா பியூரோகிராட்ஸ் பார்க்கும்போது இவ்வளவு பாசத்தோட வேற யாரும் இருப்பாங்க எனக்கு தெரியல. 1992ல 11th ஸ்டாண்டர்ட் ஜாயின் பண்ணும்போது என்னோட குடும்ப நண்பர்கள் அவரை சந்தித்தேன். அப்போ முதல் வார்த்தை சார் சொன்னது, என்னோட மதிப்பெண்ணை கேட்டுவிட்டு, எங்க இருந்தாலும் இவர் மருத்துவர் ஆய்வார் போல இருக்கு அப்படின்னு சொன்னார். ஏன் அப்படின்னு சொன்னா, போலீஸ்னு சொல்லல, இவர் எங்க இருந்தாலும் மெடிசன்ல ஜாயின் பண்ணிடுவார் போல இருக்கு அப்படின்னு சொன்னார். இன்றும் அதை நான் நினைவு கூற அந்த மிடுக்கான தோற்றத்தை. அதற்கு பிறகு 10 வருடம் அவரை நான் சந்திக்கவில்லை. 2003 நான் முதுகலை பட்டப்படிப்பு மாணவராக ஸ்டான்லியில் பணியாற்றி கொண்டிருந்த பொழுது சார் ஜாயிண்ட் கமிஷனர் சென்னை. அந்த டைம்ல ஒரு ஜவான் குதிரையிலிருந்து கீழே விழுந்தாரு. அந்த டைம் he was admitted in ICU ஸ்டான்லி. நான் சண்டே டியூட்டியில் இருந்தேன். சண்டே மார்னிங் ஒரு 10 o'clock இருக்கும். அப்போ எனக்கு இன்ஃபர்மேஷன் வந்து இந்த மாதிரி ஜேசி வராங்க ஜவான் பார்க்குறதுக்குன்னு சொல்லி. ஸோ ஐ வாஸ் வெயிட்டிங் இன் தி ஐசியூ. சார்ட்டை கூப்பிட்டு போய் எக்ஸ்பிளைன் பண்ணேன். பண்ணி முடிச்சுட்டு வெளியே வந்த உடனே, சார் நான் உங்களை வந்து 1992 திண்டுக்கல்ல வந்து நான் உங்களை பார்த்துருக்கேன் அப்படின்னு சொன்ன அடுத்த நிமிஷம் டாக்டர் கோடீஸ்வரன் சொன்னார். ஸோ மிகப்பெரிய ஆளுமைகள் அவர்களுக்குள்ளே ஏதாவது ஒரு சிறந்த குணாதிசயம் இல்லாமல் ஆளுமையாக மாறுவதில்லை என்பதற்கு சார் வந்து ஒரு சிறந்த எடுத்துக்காட்டு. ஸோ நேரமின்மை காரணமாக அவருடைய அறிமுகத்தை குறுகியாக முடிக்கிறேன். சார் born in 5th June 1962 in Kulithuri, is a 1987 batch IPS officer, completed M.S.C Agriculture, PG, L, MA, MBA, Ph.D in Criminology. Sir is known to follow a strict training regimen and has written a Tamil book on physical fitness. He has actively participated and supported various sport activities such as swimming, athletics, shooting and cycling. He has held various positions: ASP, Superintendent of Police, Deputy Commissioner of Police, DIG Vilpuram Range, JC Chennai, DIG Tiruchirappalli, CVO Karur. Sir also served as Commissioner of Police in Coimbatore and became IG North Zone Chennai, ADGP Coastal Police, Railway Police, and Sir was promoted in 2019 as DGP Railway Police. In 2021 June, Sir took charge as DGP of Tamilnadu Police. And he has got many awards, twice President Award, one time CM's Award. Next. Sir authored various books, among them 2 popular books, You Can Become an IPS Officer and Sadhika Asaipadu. Thank you, sir, for consenting us to come as a guest of honor today.
Thank you, sir. I would like to request HOD sir to kindly felicitate our special guests with a memento and a sampling of the golden plant, Sarakanda. Thank you, sir. Now, I would like to request our guests to kindly start the inauguration ceremony by lighting to the video. Thank you, sir. Next, we will inauguration of our Neurosurgery Academy at KMC.
Now, sir is inaugurating Neurosurgery Academy and Cadaver workshop. Now, we are inaugurating a special spine clinic for police personnel in association with Institute of Radio Diagnosis. And Institute of PMR. Sir will release the resection manual for this workshop. DLP Madam and President will see this. Neurosurgery Academic Manual.
Thank you, sir, ma'am. Now we would like to request Chief Guest AME ma'am to kindly deliver her initial address.
So one minute. Good morning, all of you. Respected DGP sir, thank you for coming and honoring us actually. And for this started with the scrape actually from the basement without anyone, just one manpower. This neurosurgery department started, and this Professor Dr. Kodeeswaran and Dr. and then to all three together, they have done a wonderful job for this starting of this Neuro Academy plus the workshop, and also for the police personnel, the back pain clinic. Everything should be appreciated, and really I thank the expert team from all the departments. I mean, the neurosurgery, not only neurosurgery, ENT, and anesthesia. Everybody has come here, including PMR, from come here to facilitate this Department of Neurosurgery of KMC. I really thank all the experts for this. They're going to give an expert their knowledge and skill to the youngsters so that the needy, poor patients also will be benefited, the service will be better, and also the youngsters will be learning in a proper way. So by that they are inculcating the proper knowledge and skills to the youngsters. Thank you very much, sir.
Now, அனைவரும் எதிர்பார்க்கும் சைலந்திரா சாரோட ஸ்பீச். சார் வந்து ஒரு மிகச்சிறந்த பேச்சாளர். So welcome sir. Special address.
Thank you, Dr. Cadaver. Respected Director of Medical Education, Dr. Respected Dr. Susila, Dr. Begum, distinguished senior doctors, young doctors, ladies and members of the press and television, ladies and gentlemen. It is really a proud privilege today to meet all of you and to be the part of the inauguration of the Neurosurgery Academy. Okay. Correct word, Neurosurgery Academy is a great achievement. I'd like to congratulate all us doctors, especially Dr. Prof.Dr.R. He has already mentioned that we know each other 40 years.
30 years.
30 years before, yes. 1992. So after that, we are friends. Only because of that, he invited me. So this is a government hospital, government medical college, government அரசு மருத்துவக் கல்லூரி, அரசு மருத்துவமனை பெரிய சேவை செஞ்சுட்டு இருக்குது. 5000 பேர் ஓகே இருக்கிறாங்க, வெளியில் வந்துட்டு இருக்கிறாங்க. இங்கே 1000 பேர் இருக்குது. நான் போன வாரம் திரு வால்டர் தேவாரம் கேள்விப்பட்டிருக்கீங்களா? முன்னாள் டிஜிபி வால்டர் தேவாரம் அவர்களை உடம்பு முடியாமல் அவர் தப்பி தயாரித்தாரு. ஜிஹெச் அவரை கவனிச்சேன். டாக்டர்கள் ரொம்ப நல்லா கவனிச்சிருந்தாங்க. நல்ல வசதியாக இருக்குது. அரசு ஆஸ்பத்திரி தான். 20 சீட்டு தான். அதாவது நேர்மையான அரசு குடிசலுக்கு இருக்கக்கூடிய ஒரே புகையினா அரசு மருத்துவமனை தான். அரசு மருத்துவமனையில் இது போன்ற நியூரோசர்ஜரி டிபார்ட்மெண்ட், நியூரோசர்ஜரி அகாடமி ஆரம்பிப்பது என்பது அரசு ஊழியர்களுக்கு பிரயோஜனமாக இருக்கிறார். Thank you very much. So we are, as government servants, we are extremely delighted that such a facility is available in the government Kilpauk Medical College. Particularly, என்ன மாதிரி ஆள் வந்து விளையாட்டுல நாங்கள் ரொம்ப இன்ட்ரெஸ்ட் பண்ணிருக்கு. என்டூரன்ஸ் ஸ்போர்ட்ஸ் பீப்புள், என்டூரன்ஸ் இன்னைக்குமே 10 கிலோமீட்டர் ஓடி வந்திருக்கேன். 10 கிலோமீட்டர் செய்யலாம். நீங்க எவ்வளவு ஓடிங்க தெரியும். டாக்டர்லாம் வந்து நிறைய ஓடணும். நீங்க நல்லா இருந்தா நாங்க நல்லா இருக்க முடியும். டாக்டர்கள் வந்து ஹெல்த்தியா இருந்தா தான் சமுதாயம் ஹெல்த்தியா இருக்கும். தான் சமுதாயம் நாங்கெல்லாம் ஏன் சிரிக்கிறோம், ஏன் நல்லா இருக்கிறோம்னா யாரு காரணம்? எல்லாருக்கும் நீங்க தானே. நம்மள மாதிரி பொதுமக்கள் வந்து இன்னைக்கு மகிழ்ச்சியா சந்தோஷமா ஆடி பாடி வேலை ஒழுங்கா பாக்குறோம், 60 வருஷத்துக்கு கவர்மெண்ட் டிபார்ட்மெண்ட்ல ஹாப்பி வேலை பார்க்கறோம்னா என்ன யாரு பொறுப்பு? யாரு முக்கியமான காரணம்? நீங்க தான், மருத்துவர்கள் தான் காரணம். ஏன்னா இப்ப நாம வந்து விளையாட்டு இருக்கிறோம் அப்படின்னா எல்லா விதமான பிரச்சனையும் வரும். மசில் பெயின் இருக்கும், நீ பெயின் வரும், ஹிப் பெயின் வரும், சொல்ல மாதிரி எல்லா விதமான ப்ராப்ளம் வரும். நாங்க வந்து சைக்கிள் வந்து கிட்டத்தட்ட 600 கிலோமீட்டர் சைக்கிள் பண்ணுவோம். 10 பேர் சூப்பர் வந்து தொடர்ச்சியா வந்து 600 கிலோமீட்டர் யோசிச்சு பாருங்க. அப்போ அது போறதுக்கு முன்னாடி கார்டியாலஜி அப்படி கேட்டு பாருங்க, எப்படி 600 கிலோமீட்டர் பிடிக்கும் போது மறுபடியும் இருக்கோமா, திருப்பி வந்துடுவோமா, திருப்பி கம்பேக் இன் ஒன் பீஸ். அப்புறம் நம்ம வந்து நியூரோ சப்ஜெக்ட் கேட்கணும், ஏதாவது பெரிய ப்ராப்ளம் ஆகுமா அப்படின்னு. அப்புறம் ஆர்த்தோ அவங்கெல்லாம் பரவாயில்ல சார் போயிட்டு வாங்க, பிரச்சனை ஆகாது, இவ்வளவு தூரத்துக்கு லெவலில் இருக்கு. ஸோ அந்த மாதிரி எங்களுக்கு வந்து அறிவுரைகள் சொல்லக்கூடிய டாக்டர். அதுவும் எனக்கு வந்து எங்க அப்பா பற்றி சொல்லணும். எங்க அப்பா வந்து ராமத்துல வேலை பார்த்தாங்க, பக்கத்துல டிபார்ட்மெண்ட்ல. அவருக்கு ஏதாவது பிரச்சனை நான் நேராக போய் கவர்மெண்ட் ஹாஸ்பிட்டல் தான் போவேன். நான் ஏன் கேட்பேன், ஏன் பாருங்க வந்து கவர்மெண்ட் ஹாஸ்பிட்டல் அதான் உண்மையான டாக்டர் இருக்காங்க. அங்கதான் உண்மையான டாக்டர்ல இருக்கிறது அரசு. அரசுனாலும் அரசுன்னா அது அங்க வந்து இலவசம். அதனால அது ஏன்னு கேட்டேன். அவர் சொல்றாரு, எம்பிபிஎஸ் படிச்சவங்க தான் அறிவியல் பூர்வமான மருத்துவர்கள், சயின்ஸ் பேஸ்ட் மெடிக்கல் அரசு மருத்துவமனை. அப்புறம் எல்லாரும் அவங்களுக்கு தான் நம்ம அனாட்டமி, பிசியாலஜி இது மாதிரி அவங்க அங்கதான் அறிவியல் பூர்வமான மருத்துவம் கிடைக்கிறது அப்படின்னு சொல்றாரு. இது டாக்டர் கோடீஸ்வரன் எனக்கு கூட்டத்தில் எனக்கு ரொம்ப எந்த வயசு இல்லை தெரியுமா. ஒரு காலத்துல நானும் டாக்டர் ஆகணும் தான் நினைச்சேன். அப்ப ஏங்க எனக்கு ஆகலை அப்படின்னு கேட்கலாம். அதுக்கு இடம் கிடைக்கல. மருத்துவ கல்லூரி எனக்கு கிடைக்கல. அவங்க ஒழுங்கா படிக்கலையான்னு கேட்காதீங்க. நல்லா தான் படித்தேன், நல்லா படித்தேன், நிறைய மார்க் வாங்கினேன். அப்போது வந்து மருத்துவ கல்லூரி சேர்றதுக்கு இன்டர்வியூ வச்சிருந்தாங்க. அதெல்லாம் ஒன்றும் கொடுமையா இருக்கு. ஏன்னா நிறைய மார்க் வாங்கின இன்டர்வியூல மார்க் வாங்கல போகிறது. அதுக்கு மேபி நம்ம ஏதாவது என்ன கேட்டாங்களோ என்ன சொல்லணுமோ அது ஞாபகம் இல்லை. பட் இன்டர்வியூல இடம் கிடைக்கல. ஸோ நான் அக்ரிகல்ச்சர் காலேஜ் சேர்ந்தேன். அக்ரிகல்ச்சர் காலேஜ் சேர்ந்த பிறகு எனக்கு அதுல ஆர்வம் இல்லை. நான் என்ன பண்ணேன், மருத்துவம் படிச்சிடணும். அப்ப என்ன ஒரு வசதி இருக்கிறதாங்கன்னா உங்க மார்க் மறுபடியும் எக்ஸாமினேஷன் எழுதலாம், ரீ எக்ஸாமினேஷன், திருப்பி எக்ஸாமினேஷன் எழுதலாம். பிசிக்ஸ், கெமிஸ்ட்ரி அண்ட் பயாலஜி திருப்பி படிச்சேங்க. திருப்பி படிச்சு மார்க் இம்ப்ரூவ் பண்ணிட்டேன், நல்ல மார்க் வாங்கிட்டேன். மருத்துவர்கள் அப்ளை பண்ணாங்க. என்ன சொன்னாங்கன்னா, நீங்க வந்து ஏற்கனவே வந்து ஒரு ப்ரொஃபஷனல் காலேஜ்ல படிச்சீங்கன்னா இன்னொரு ப்ரொஃபஷனல் காலேஜ் சேர முடியாது, உங்களுக்கு டிஸ்குவாலிஃபை ஆகிடுவீங்க. ஏற்கனவே இந்த மாதிரி போனவங்கள அந்த மெடிக்கல் காலேஜ்ல இருந்து ரெஸ்டிகேட் பண்ணாங்க. சரிங்களா? இது அந்த வருஷம் போகாம என்ன பண்ணாங்க, மற்ற ஸ்டூடெண்ட்ஸ் எல்லாமே சேர்ந்து வழக்க போட்டு நாங்க வந்து சேரலாம் அப்படின்னு சொல்லி கொண்டு வரும்போது பியூசி படிச்சவர்களுக்கு மெடிக்கல் காலேஜ் இடம் இல்லைன்னு இருந்தாங்க. மூணாவது வருஷம் அப்படி 3 ஆண்டுகளை முயற்சி பண்ணி ஆக்சுவலி கடைசி எனக்கு கீழ்பார்க்கு போட்டி காலேஜ் கிடைச்சது. கிடைச்ச பிறகு ஒரு ஜியோ போட்டு அக்ரிகல்ச்சர் காலேஜ் படிச்சவங்களுக்கு மெடிக்கல் காலேஜ் சேரக்கூடாதுன்னு ஆர்டர் போட்டதுனால 4வது வருஷம் அதுவும் இருந்துச்சு. அதான் மருத்துவ கனவு. நான் ஏன் சொல்றேன்னா, இன்னைக்கு லட்சக்கணக்கான இளைஞர்கள் மருத்துவ அறிவியல் ஆசைப்படும் போது அந்த வாய்ப்பு அவங்களுக்கு கிடைக்காம உங்களுக்கு தான் கிடைச்சிருக்கு. வெரி ஸ்பெஷல், வெரி லக்கி. ஸோ அது வந்து அந்த ப்ரொஃபஷன் என்பது மக்களுடைய உயிரை காப்பாற்றக்கூடிய மிகப்பெரிய ப்ரொஃபஷன் அப்படிங்கிற ஒரு ஃபீலிங் மருத்துவர்களுக்கு கண்டிப்பாக இருக்கணும். மருத்துவ தொழில் நிறைய கஷ்டங்கள் ப்ராப்ளம் இருக்கு. அதெல்லாம் சேலஞ்சு சொல்லுவாங்க, டாக்டர்ஸ் அந்த மாதிரிலாம் இருக்குது, எங்க மேலே கேஸ் போடுறாங்க, அந்த மாதிரி அதெல்லாம் இருக்கு. அதெல்லாம் இருக்கு டாக்டர், அதெல்லாம் சவால்கள், சேலஞ்சு இல்லைங்களா? சமுதாயத்துக்கு வந்து எது உண்மையான மருத்துவம், எது பொய் மருத்துவம், எது உண்மையான டாக்டர், எது போலி டாக்டர்னே தெரியல. இன்னைக்கு கூட சிபிஐ ரைடு பண்ணிட்டு இருக்கு போலி டாக்டர். படிக்காம நானே டாக்டர் அப்படின்னு இருக்கவங்களுக்கு நிறைய ரைடிஸ் இருக்கு. எந்த அறிவியல் உண்மையும் எந்த பயிற்சியும் இல்லாமலே நிறைய பேர் மருத்துவர்கள் சொல்லிட்டு நம்ம ஊர்ல எல்லாருமே மருத்துவர் தானே, எல்லாருமே மருத்துவர். நீங்க யாராவது உடம்பு முடியலன்னு சொல்லி பாருங்க, அவங்க உடனே ஒரு மருந்து சொல்லுவாங்க. ஏதாவது இந்த மாதிரி சுற்று மலகு சுற்று ஏதாவது யாரும் சாப்பிட தெரியாம போயிடும். வங்கியில் படிச்சிக்க மாட்டாங்க. அவங்க ஒரு மெடிசன் சொல்லுவோம். எல்லா மக்களுமே பிடிச்சது. ஆனா அது தப்பு, அது வைக்க கேடு, நம்ம அப்படி சொல்லக்கூடாது, டாக்டர் தான் சொல்லணும் அப்படிங்கிற ஒரு அடிப்படை ஒரு டெஃபினிஷன் நம்ம ஊர்ல இல்லை இல்லைங்களா? யாராலும் அவங்க மெடிசன் சொல்லிடுறாங்க ஏதாவது. ஸோ அந்த சூழ்நிலையை உங்களுக்கு பார்க்க கஷ்டமான ஒரு சூழ்நிலை இருக்கு. இருந்தாலும் நம்ம நாட்டில் வந்து 194 கோடி மக்கள் இருக்கிறாங்க. அவங்களுடைய உடல் நலம் முக்கியமான உடல் நலத்தோட தொடர்புள்ளது மனநலம். Mental health also is closely associated with physical health. If somebody is losing physical health, naturally his mental health will not be happy person. His productivity will not be good. Quality of life will not be good. So அதோட தொடர்புள்ளது தான் இந்த மிகப்பெரிய பொறுப்பு உங்களுக்கு இருக்கு. இப்போ அட்வான்ஸ்மெண்ட் இன் சயின்ஸ் அண்ட் டெக்னாலஜி இன்னைக்கெல்லாம் மருத்துவ துறையில ஒரு பெரிய விஷயம் வந்து பெரிய பெரிய மிஷின்ஸ் வந்தாச்சு. இந்த காலத்தில் டாக்டர் யார் நல்ல டாக்டர் எங்க ஊர்ல நோய் என்ன கண்டுபிடிச்சாருன்னா அவர் தான் பெரிய டாக்டர் இல்லைங்களா? எங்க ஊர்ல டாக்டர் ஜெயசேகரன் ஆஸ்பத்திரி ஜெயசேகரன் இருந்தார். ரொம்ப அவர் வந்து அந்த பேஷண்ட்டை பார்த்தாலே அவங்களுக்கு இந்த பேஷண்ட்டுக்கு பாதி நோய் போயிடும். போட்டு அவங்க நல்லா கரெக்டா ஸ்டடி பண்ணி கரெக்டா கண்டுபிடிச்சுவாரு. ஏன் சொல்லணும்னா எங்க அப்பாவுக்கு இருந்த பிரச்சனை அவர் தான் கண்டுபிடிச்சாரு. டாக்டர் ஜெயசேகர் எங்க அப்பா வந்து டூரிஸ்ட்ல யாருக்கும் தெரியல. பெரிய பெரிய வைத்தியர்ல போடுறாங்க. வைத்தியர்னா ஊர்ல இருக்கக்கூடிய அந்த கண்ட்ரி பிராக்டிஷனர்ஸ் அவங்க காலம் நடத்திட்டாங்க. அவங்க என்னென்ன பொருள் அவங்க என்னமோ கஷாயம் கொடுத்து பார்த்தாங்க. எங்க அம்மாவுக்கு புரிஞ்சு போச்சு வந்து கொஞ்சம் கஷ்டமா அப்படின்னு சொல்லி எங்க அப்பா கூட்டிட்டு போய் டாக்டர் ஜெயசேகர் அட்டாச் தான் சொல்லிட்டாரு. இது டூரிஸ்டியா உடனே சர்ஜரி. அது ஃப்ளூயிட் நினைக்கிறேன். அந்த லங்ஸ்ல என்னமோ ஃப்ளூயிட் இருக்கும். பார்த்தா லங்ஸ் தெரியல. அது ஒரு இன்ஜெக்ஷன் போட்டு டக்கு எடுத்தாரு. அதுக்கப்புறம் சரியா போச்சு எங்க அப்பா. டாக்டர் வந்து அவர் தான் அந்த ஊர்ல கடவுள் எங்க ஊர்ல. ஏன்னா டயக்னோசிஸ் இன்னைக்கு அது வந்து வேண்டாங்க. நிறைய மிஷின் உள்ள ஆளை உள்ள போட்டு விட்டீங்கன்னா மிஷினே காட்டிடுது. இவர் கார்ல 3 பிளாக் இருக்கு, நாளை எடுத்து போயிடுவாரு. இன்னைக்கே சர்ஜரி பண்ணணும். அவன் வந்தாலும் உடனே போய் தான் பார்ப்போம். உடனே பண்ணணுமா இல்ல அடுத்த வருஷம் பண்ணா சொல்லுமா? அவர் சொல்லுவாரு அடுத்த வருஷம் பண்ணா சொல்லுவோம். அதுக்குள்ள அவங்க போயிடுவாரு. ஸோ மிஷின்ஸ் நான் வந்து டிஃபரன்ஸ் ஸ்லைஸ் பண்ணக்கூடிய மிஷின்ஸ் டிஃபரண்ட் கைண்ட் ஆஃப் மிஷின்ஸ் அது வந்து இப்போ சர்ஜரியே மிஷின் பண்ணக்கூடிய அளவு வந்து
robotics.
பட் அல்டிமேட்லி தி டாக்டர் இஸ் a very important person. அவர் தான் டிசிஷன் எடுக்கணும், அவர் தான் ரிசர்ச் பண்ணணும். ஸோ ஃபியூச்சர் வில் டிபெண்ட் அப்பான் நாலேஜ் டாக்டர்ஸ் ஹைலி குவாலிஃபைட். அதான் பீட்டர் ட்ரகர் அவங்க மேனேஜ்மெண்ட் கிராஜுவேட். பீட்டர் ட்ரகர் ஒரு பெரிய மேனேஜ்மெண்ட் குரு இருக்கார். பீட்டர் ட்ரகர் திஸ் வேர்ல்ட் இஸ் a world of knowledge workers. ஆல் டாக்டர்ஸ் நாலேஜ் கிடைக்கல, நாலேஜ் கம்யூனிட்டி. காவல்துறையிட்ட நாங்கெல்லாம் போலீஸ் ஆஃபீஸர்ஸ் எல்லாம் சேர்ந்து ஒரு கான்ஃபரன்ஸ் நடத்துவோம். விமான ஓட்டிகள்லாம் சேர்ந்து தனியாக நடத்துவாங்க இல்லைங்களா? ஸோ அது மாதிரி அந்தந்த ஃபீல்டில் உள்ளவங்களோட இன்டராக்ஷன் செய்யலாம் ஃபியூச்சர் நாலேஜ் ஒர்க்கு. ஸோ இனி எதிராக வந்து மருத்துவத்துறை வந்துங்க அறிவுபூர்வமான தொழில்நுட்பபூர்வமான ஸ்கில் பேஸ்ட் மெடிக்கல் ப்ரொஃபஷன் தான் பிரச்சாரம். ஸோ அந்த வகையில் இங்கே நியூரோ சர்ஜரி அகாடமி ஆரம்பிச்சிருக்கு. வாழ்த்துக்கள். காவல்துறையில வந்து எப்பவுமே பிசிக்கல் ஒர்க் கஷ்டமா இருக்கும். பாருங்க, ஒரு சார்ஜ் கண்ட்ரோல் பாருங்க, 4 hours டியூட்டி, அப்போ 1 or 2 hours பிரேக், அகைன் 4 hours டியூட்டி, வேற ஒர்க் இருந்தாலும் திருப்பி வரணும். ஸ்டாண்டிங் ஆல் த டைம். ஸோ நேச்சுரலி அவங்களுக்கு நிறைய பேக் ப்ராப்ளம் பேசலாம் வரும். ஸோ அவங்களுக்கு ஒரு ஸ்கீம் நம்ம இங்கே ஆரம்பிச்சிருக்கிறோம். அவங்களுடைய செக்கிங் பண்ணிட்டு அவங்களுக்கு தேவை இருந்ததுன்னா மெடிக்கேஷன், இல்லைன்னா பிசியோதெரபி, இல்லாட்டி அல்டிமேட் சர்ஜரி. அந்த மாதிரி எனக்கு கூட ஒரு வாட்டி சர்ஜரி பின்னாடி வந்து பேக் பெயின் சர்ஜரி பண்ணணும்னு சொன்னாங்க. அப்புறம் தான் டாக்டர் சொன்னாரு, ஆர்த்தோ டாக்டர், அதெல்லாம் வேண்டாம் சார், நமக்கு வந்து பிசியோதெரபி பண்ணி பேக் ஸ்ட்ரென்தன் பண்ணிடுவோம். ஸ்ட்ரென்தன் பண்ணிட்டு 1 கிலோமீட்டர், 2 கிலோமீட்டர், 5 கிலோமீட்டர், 10, 20, 25, 30, 35, 42 கிலோமீட்டர் வந்தாங்க. 6 கிலோமீட்டர் காஷ்மீர் கன்னியாகுமரி வரைக்கும் ஓட்டாங்க சைக்கிள். 4500 கிலோமீட்டர் மெடிக்கல் அட்வைஸ். அடுத்த எவ்வளவு தூரத்துக்கு வந்து கொடுத்தாங்க. டாக்டர் பார்த்து சொன்னாரு, படத்தை பார்த்துட்டு, இது வந்து பாடல எல்லாம் கேர்ஃபுல்லாக இருக்கணும். ஸ்ட்ரென்தனிங் ரொம்ப பெரிய சொல்யூஷன் இல்லைங்க. ஸ்ட்ரென்தனிங் தி பேக். இப்படி மருத்துவ சயின்ஸ் வந்து நிறைய டேக்ஸ் வந்துட்டு இருக்கு. நம்ம லைஃப் ஸ்ட்ரென்தன் பண்ணுறதுக்கும் நல்ல வாழ்றதுக்கும் அதுக்காக டாக்டர் நாங்கள் டாக்டர் நன்றி விரும்புகிறேன். சென்னையில் மட்டும் 20,000 காவலர்கள் இருக்கிறாங்க. அவங்க எல்லாருக்குமே இந்த பேக் ஸ்கிரீனிங் நடத்தி
every third Monday
நீங்க நடத்தி அவங்களுக்கு வந்து ட்ரீட்மெண்ட் பண்ணுறாங்க. இதுதான் என்னுடைய ஹைலைட். போலீஸ் பீப்புள் காவல்துறை சேர்ந்தவங்களுக்கு போதுமான இந்த சிகிச்சை இங்கே வழங்கப்படும். அதுக்காக நன்றி மேடம் அவர்களுக்கும், டைரக்டர் மெடிக்கல் எஜுகேஷன் அவர்களுக்கும், டாக்டர் கோடீஸ்வரன் அவர்களுக்கும், அவரை சேர்ந்த அனைத்து டாக்டர்கள். அவங்க ரொம்ப முக்கியம் இல்லைங்களா? அவங்க வந்து நர்சிங் ஸ்டாஃப், டெக்னிக்கல் ஸ்டாஃப், அவங்களாம் ரொம்ப முக்கியம். ஆல் பார்ட் ஆஃப் த ஹோல் டீம். அவங்க எல்லாருக்கும் எங்களுடைய காவல்துறை சார்பாக நன்றி தெரிவித்துக்கிறேன்.
Now, I request DGP sir to felicitate Department Neurosurgery staff. Two staffs of our department, Dr. Anil Kumar Tyagi and Dr. Mahikamal Goswami, will be honored by DGP sir and DNE madam. So Yuvraj, ward manager, is giving 24/7 support to our ward department. So I request DGP sir to give a medal to this. Honorable Pushpam, OT in charge staff nurse. Nirmala, in charge neurosurgery staff nurse. Ravi and Nandini, OT technicians. They are serving 24 hours. One person is doing day duty, another person is doing night duty. OT technicians. Now I request DGP sir to felicitate our associations. I request ANS office bearers, Dr. Arun Kumar sir, Dr. Murugan, Dr. K.V. Karthikeyan to come for the felicitation. I request office bearers Dr. Nagan Narayana, Dr. Raghavendran, Chennai Neurosurgery Association for felicitation. I request Dr. Rupesh Kumar, Kalpe Society of India for felicitation. I request Dr. Nadavani Shanmugam, who came all the way from Chandigarh, Neuroendoscopy Society of India. Now I am presenting one good book to DGP sir, to DV madam, for participating. Sir is coming for a function. Thank you sir, thank you for coming here and felicitating us.
Sorry, sir. What do you want to say?
Open diary, sir.
Can you take your seats, please? We will enter the next session. I call upon Dr. V. Rupesh Kumar, Consultant Neurosurgeon of Proton Hospital, to deliver this lecture on endoscopic endonasal approaches to diverse surgical settings.
Thank you, Chairperson. Colleagues and friends, I also thank M.Kodeeswaran for this program, and Salvation Society of India is very happy to complete this program on endoscopic and another course on Salvation Anatomy. Both such programs are required to actually supercenter and systematic cover diseases, and still are principles of approaches. I will now concentrate on intracellular pathology. As you know, mycosis is one of the most difficult approaches to the area to approach. It's both for microscopic as well as endoscopic approach. So conventionally, all these glial tumors are approached through extensive skull-based approaches, through posterior vitrectomy, anterior vitrectomy, total vitrectomy is very monitored. However, with the advent of endonasal endoscopic approaches, these areas can be approached relatively easy than conventional microscopic. So this is the endoscopic cadaver anatomy. This is what we are going to see today, and I will show you some of the live surgical procedures and how this is the anatomy. What you see, you can see that the entire approaching the endoscope, we can entirely approach the whole of the climax. We can expose all these to the brainstem cords. The relative is which are once upon a time were very difficult to reach with the any other approach microscopy. So this is the typical appearance. So you can see that the first picture, the cellular, the workhorse is the sphenoid sinus. So to reach to the virus also, we need to have a wide sphenoidostomy. Only thing is, we need to go more and more interiorly to go expose the paraclavial carotid. You can reach up to the C1, C2 junction as you dissect down interiorly by extensive approaches like transcerebral approaches, as you see here. The most important anatomical landmark in this area is the median nerve. The median nerve aids you to the horizontal and the vertical ICA, and that is the landmark which has to be identified before contemplating on these surgical procedures. So transcerebral approach is what such approach, it's an extended endoscopic approach. by removing the maxilla, the posterior of maxilla, and the endoparatid cortex, you skeletonize structures, the neurovascular bundle, you identify the median nerve, divide it, and the whole bone centrally intermediately to have a context approach, the binocular technique, your grounding of instruments will not happen with this approach. So various approaches are there to transfer the gut, and the lower level is one which can be approached very well with these approaches. So just go to some of the examples. As you see here, this is the clival meningioma. It is involved in the mid third of the clivus, and you can see that the visceral artery is affecting the medial margin. One can approach this tumor endoscopically, but I think endoscopy gives you a midline corridor, and it's not a very big tumor, and it can be relatively approached well with an endoscopic approach, so minimally invasive approach. So this is the nasoceptal flap. So as you see here, so for clival defect, you need to have a good nasoceptal flap to cover, because there is no tamponade effect in CSF fistula, and it's one of the notorious complications of the dissection. So this is the principal article I showed you the videos of an nasoceptal flap, how much you harvest, all those principles, and we're going to repeat it. You can see that the monopolar was used, but now we have almost stopped using monopolar for harvesting. We use sharp blade because they're much healthy if you are doing it with a blade rather than using monopolar. So once you do binocular technique, so there is a sphenoid rostrum, so you are ripping out. That's the principle. You expand the opening. So why the sphenoidoscopy is approved? That is the cella. So once you reach the clivus, then you expose the paraclaval carotid, then that's the landmark. So this is a nice picture of the paraclaval carotid cella, and then you with the help of navigation. If you have navigation, it's very good. You don't have, there's a good fixed anatomic landmark, so you know where the tumor is, and you can start drilling it. You can see you go immediately. This controllable hemostat is very helpful to achieve hemostasis and which will be takes a lot of time. So this controllable hemostat actually helps. Otherwise, the clival dura is very vascular. A lot of venous pressures are there, and they keep bleeding, and they increase our operating time, and it's just frustrating sometimes. So with the advent of this global hemostat, it's easy. That is the clival dura. So you make an incision, you make a flap, and directly landing on the tumor. The advantage, as Dr. Tatman is mentioning, once you remove this tumor, remove this dura, already you revascularize the tumor, and that is the venous pressures again. The hemostat will help you in achieving. You start removing this tumor by piecemeal initially, and you can see this is very, very firm. Unlike the supracellular, the clival meningioma are invariably very firm to cut, so you need to use a sharp and blood dissection reading technique. That is the visceral artery, as you see here. So that is a brainstem. So you're dissecting the tumor. There's a cup bianca dissector. It's very, very useful. So you are working between the visceral artery and the pons. You can see that area that's quite adherent. So with the blunt dissection, it may not be very safe. So you may have to use sharp dissection with micro scissors to release the tumor adhesions from the brainstem. And so you go all around the tumor. So you have already seen the medial border, and now you have to go to the superior border. So with this kappa bianca fine dissector, you can sweep the tumor all around, and you identify all the corners of the tumor. And you are trying to identify the superior extent of the tumor, and we can see that slowly, and that is the arachnoid of the interpedunclar cistern. So you know the anatomy, so that is the superior extent, and now you go to the lateral extent. So you develop a little bit more tumor so that you can go all around, and then the lateral is free, so you can see that the whole tumor can be delivered like this, and you can see that finally you deliver the tumor all around, and you can deliver the clival meningioma. So this is relatively simple if you can do endoscopically, but with microsurgery, you can see we have to work through all the cranial nerves, putting into the stretch of all the cranial nerves, and so endoscope scores over this technique compared to microsurgical. So you can see there's a direct access to the clival tumors, and you can see the visceral artery in the center, and you can see that amount of the bony opening, and it's one of the very minimally invasive techniques. Chordomas are the indications for endoscopic intranasal approaches. As you see here, this is a recurrent chordoma. Earlier, the biopsy was done, and this patient was referred as to proton therapy. But however, we see that there's a lot of tumor there. It is involved in the Meckel's cave, it is involved in cavernous sinus, the cella, the clavus, and the petrous apex. And what nodule is there? You can see that it is poking into the brainstem. So to deliver a proton as a therapeutic dose, you have to clear the tumor away from the brainstem so that you can cure these diseases, and we can see that. So I'll just show it through the operative video. And again, this is a bilateral transpterygoid approach. So all these clival chordomas, extensive chordomas, you need to have that is the pterygoid process removing. You can see with the help of navigation, you can identify the edges of the tumors, and we can see there's a
dorsum cellular drilling there, and you can see you have exposed the inferior part of the cellar. You need not completely deal with the cell in this case because it's more down in the upper and middle clavus, and you can see this. Unlike pituitary tumors, chordomas are very firm and hard, so it becomes more extensive to remove, and we can see that is the petrous apex. So with the help of transcervical approach, you can access the petrous apex and you continue to remove this tumor extradurally. Primarily chordomas are extradural, but sometimes in recurrent cases, sometimes in primary also, you can invade the dura and go into the subarachnoid space. And you can see with the help of an angled endoscope, we can say that is the angled endoscope, and you can use angle suction tips, and we can remove these tumors, the petrous apex, with ease because you have done already the transcervical approaches. So once you are removed, and you continue to remove the tumor, and you can see how firm you need to have micro scissors, and these are very firm tumors. So once you have cleared the extradural portion, now they remove the portion which is going intradurally, pressing the brainstem, intending it. So that's the dura we are incising. You can see the visceral artery there down, and we can see the perforators. So it's very important that all these small perforators, and these are brainstem perforators which has to be, and that is the tumor which is intending the brainstem. And we can see that the perforators we need to be very careful about, and that is a tumor which is intending, and that has been removed there, and you are seeing the glimpse of the sixth nerve on the left side, and you can see the gross total excision could be achieved, and it is important to have a good reconstruction. So my and Kripa work together in all these cases, the binostril technique, and we can see that how much it is. That is a postoperative MRI, and we can see that the nodule which is pressing on the brainstem has been removed. Much more extensive diseases like this is the lower clavus extending down to the CV junction, involving the C1 and C2. As you see here, the medulla and the inferior parts has been pushed significantly posteriorly, and that is the. So Kripa has given a very good exposure bilateral transcervical approach. You can see that the bilateral, the clavicle bone is extensively destroyed. You don't have anatomy because there's no bone, so navigation is helpful. And you clear these tumors, the parapharyngeal. There is the odontoid drilling endoscopically. So because the tumor has got behind the odontoid, so you have to remove the C1 arch and odontoid process so that you can have exposure. Here you see this is a mixed tumor, soft to firm. Some tumors are firm, some tumors are soft. And as you see here, it is already breached the dura. You see the glimpse of the visceral artery there. That is a pons, and you can see this the tumor gone subarachnoid space. Usually clavicle chordomas are extradural, but in this case it has gone subdurally into the subarachnoid space with multiple compartments. You see there are two compartments: the visceral artery, the vertebral junction, and you're going to either side, and doing the inferior part of the tumor, you can see nicely the visceral, and that is the tumor which is invading the rootlets of the C1 and the hypoglossal nerve. So you remove this tumor comfortably. You can see up to C2. You can see because of this approach, you can see cephaloramic view of the whole medulla oblongata and the upper cervical cord, and you can see the rootlets are so nicely arising. They use angled endoscopes to visualize the side corners of the tumor, make sure that all the side tumors are removed, and that is the lower cranial nerves going into the foramen of Blushka on the left side, and you can see that the whole tumor has been cleared completely in those cisterns, and you can see the nice pulsation, the pons of the visceral vertebral junction. Similarly, you also visualize the corners. So that is the advantage of the endoscope. You can tilt the endoscope and you can see all the corners and clear all these tumors completely. And you can see there's an artificial dura, and you have robust reconstruction is very important. I think Kripa is very good in that he has already shown that. So this is the final picture. So we always use gasket technique, and fat multi-layer reconstruction is very important, and that is the nasoceptal flap, and that is the end of the procedure. So I think so. This is the postoperative MRI, and that is the fat suppression images. So you can see that almost a gross total excision could be achieved. I think skip because we need time for our endoscopic. Do you have time or can we skip? Yeah, time? Sure. Okay. So this is again a large chordoma. I operated earlier in AIMS, and then this patient had a sheath-keeping recurrence. Again, it is not more of extradural, it's more of intradural and subdural. You can see again the pressing the middle oblongata here. The previous case I showed the tumor indenting the pons. In this case, it is indenting the middle oblongata as you see here. And so again, this is a tumor. I think I can quickly run through it. Okay, not able to fast forward. So here already it is a redo case, so the anatomy sometimes will be distorted. So this is the transcervical approach we are showing. So this is very important to have bilateral. Whenever we want to reach the lower clavus, we have a transcervical approach because your instruments will not count at the lower part of the CV clavicle and the upper part of the CV junction. So you can see that's a peligraphy drilling, and the biliary nerve is very important in this case to identify. You can see that is a tumor, and this is soft to form. In redo cases, the anatomy plane is lost, so you have to be extremely careful. Here is already indenting the vertebral artery, and we can see the vertebral artery is encased with the tumor. So you need to be very patient, very meticulous dissection, and you can see the arachnoid is there, and the vertebral artery has got to see in the vertebral artery. So you go down till the lower part of the tumor is seen, and that is almost the C1, C2 dura, and you use a combination of soft and full dissection. And that is the component which is burrowing into the medulla oblongata, so you decompress it. It is very important to remove the tumors which are burrowing into the brainstem, because if you want to give a proton therapy, you have to clear the tumor away, and it will be a therapeutic dose. You can go for 75 grays, a very, very high dose, which brainstem cannot tolerate. So it's important that you clear the tumor away from the brainstem. If you can leave behind the tumor on the bone, that is not a problem, but it should be very, very clear from the brainstem. So that is the final portion of the tumor, small nodule, you can see, and the tumor was a little bit going down, so we are drilling the C1 arch, and the C2, we make sure that we remove it, that is the lowermost part of the tumor, and we can see that the whole cervical cord has been exposed, upper cervical cord, to remove the tumor extensively. This is very, very extensive disease, very large defect. You need to have a very, very robust closure in these type of tumors. So that is the preoperative MRI, as you see here, burrowing into the medulla, and you can see that is the multi-layered reconstruction. The whole tumor and the medulla, upper cervical cord have been decompressed, and the tumor burrowing into the medulla also has been cleared. So endoscopic, this is the advantage. Whatever approach you use microscopically, it will be impossible to reach and remove this part of the tumor without much significant damage, whereas an endoscope can achieve these type of tumors very easily. Again, this is an upper clavicle chordoma, again recurrent, as you see here. So this is the upper and cellular sphenoid sinus, and you can see that is the here the paraclavial carotids are very, very narrow. So each case is different. So again, so this needs wide drilling. So that is the this case we drill the dorsum cellae, and that is a dorsum cellae drilling, and you can see the upcut shouldn't be used very, very cautiously. That is a carotid artery, clavicle carotid. You can see that is a paracellular carotid. So use upcut just to remove the bone after thinning it, not with the thick bone. So that is a previous fat graft which was kept. So we have to remove. All these redo cases are quite difficult. So with the navigation, however, it becomes easier to identify the planes, and you can see this is more calcified, more firm and more hard, as you see here. So you continue to remove this tumor, and you can see once you identify the edge, and you will see shortly the interpeduncular cistern. So that is the arachnoid of the interpeduncular cistern, the basilar artery, the third node there, and you can see there is a margin. So you continue to dissect the litigation membrane. So here, this is primarily an extradural disease. It does not breach. There's a good layer of dura there. So it's important that sometimes the involved dura has been to be resected. And you can see, you have the edge of the interpeduncular cistern on the left side, and you know how much the depth is the tumor. This tumor has gone more towards the right side. So you can see there is a tumor which is gone. Again, in this case, it is close to the optic chiasm and the optic nerve. Again, to give a therapeutic dose of proton, it is better to leave behind space between the optic nerve. Otherwise, you may have to give therapeutic dose to 75 gray to the optic nerve, which is not tolerable. So you clear the tumor more, as you see here. So the chiasm optic nerve has been cleared, and you can see continue to remove the tumor. Unlike the previous two cases, this is more hard and more calcified, and it becomes again extensive, important to have a very wide exposure. That is reaching the lowermost part of the tumor nodule, and you continue to remove the tumor with the various combinations of a sharp and blunt dissection, and you can see here. So, and that is the postoperative MRI, as you see here. It's going clear, and the optic nerve, optic chiasm is free, the brainstem interpeduncular cistern is free, and we can give. So this is the last case. You can see this multiple, 4 times operated, giant invasive involving the clivus. You can see the whole clivus. It's a giant invasive pituitary adenoma. They are also one of the most, they behave like malignant tumors, though they are benign. As you see here, it's multiple pseudopods extending into the paracellular, pyramidal sinus. More important, you can see up to the lower clivus, pituitary adenoma. These are not very common scenarios. And you see the moment you put the scope, you're already seeing the tumor there exposed. And you can see, continue to remove this tumor. And here, it's important that this is already operated 4 times, and so he has not yet received radiation therapy. So we wanted to debulk this tumor before giving radiation. You can see. So this sometimes pituitary tumors can be soft to firm. Most of the time they are firm, especially these type of invasive adenoma, and they are sometimes extremely vascular. So first thing is, because already multiple times operated, there is no anatomy. The whole nasal anatomy has already been involved. So to identify the normal anatomic structures is very important. And so you go to the margins and find out what are relevant anatomy, and then you start debulking the tumor. So just fast forwarding it. So you go this again. reaching the clavus, you need to have a transpsyrigoid approach. So bilateral transpsyrigoid, so we are together operating this case. So you can see here, it's very vascular. And so you continue to debulk the tumor. And as you debulk the tumor more and more, you get to see the anatomy. And that is the maxilla, posterior wall of the maxilla, for the transpsyrigoid approach. So you remove the posterior wall of maxilla so that you can go to the transpsyrigoid. So you can see that is once you remove the posterior wall of maxilla, you have the pterygopalatine contents, the avascular plane, you can dissect it, push the whole neurovascular bundle. Again, there's a tumor component there. So here the median nerve comes into the play. I'll show you in the short form. There's a perpendicular plate of palatine bone. So this, I think ENT surgeons will be more comfortable familiar with anatomy because they have Dr. Kilpauk here. So will be comfortable operating these cases with him. You can see. So that is the left median nerve. So you can see that once you divide the median nerve, you can push the whole neurovascular bundle of the pterygopalatine fossa contents so that you expose the whole of the pterygoid plates, and you can have a transpsyrigoid approach. Transpsyrigoid approach is something like doing an FTOEZ instead of a periodal craniotomy for the skull base if you are operating on the microscopic approaches. So that increases the corridor to work around these difficult corners of the clavus, especially the lower clavus, so that you can go around with ease. So this video is to show how you do a transpsyrigoid approach. Again, the right side, you do the same thing on the right side also. The right posterior wall of maxilla is removed. So these type of recurrent tumors, you need to have such extensive endoscopic approaches so that, and once you can remove, again you know that the cavernous sinus portion will be left behind in this case. So this is the right pterygopalatine contents which are retracted laterally. The tumor is in view. So multiple pseudopods tumors, some multi-compartments. Again, the right median nerve has been destroyed by the tumor here already. So we need not do that. So we'll push it. So working around in the corners. And that is the final picture of the tumor. You can see that the whole anatomy, that's the clavicle recess, the nasopharyngeal soft tissue. We could remove the whole of the tumor till the clavicle dura. Fortunately, the dura was not exposed except for a small area of arachnoid breach, which you could repair it. So that is the inferiormost portion of the tumor, the lowermost part of the clavus. So you can see the right median node, that is the right median node. So just for the anatomy, the petrous ICA continuing as a paraclaval ICA there. So that is the important anatomical landmark for the ICA, because whatever bone inferior medial you can drill, you cannot go superiorly, you may injure the paraclaval carotid artery. So that is a right paracellular. Once you have done all those things, then we go into the paracellular component to remove the tumor of the cavernous sinus. You are seeing that arachnoid there, arachnoid pulsations in the cella. So we know that we have removed the tumor almost grossly. And finally the hemostasis. So you can see with the help of the navigation, we make sure that where we are at the end of the procedure, and so this is important. So that is the median nerve on this right side divided one. So the crux of this presentation is to show how you extend the corridors of the endoscopy to reach these difficult locations in the clivus and the lower aspect of the tumor to have exposures. Again, that's a post-operative MRI. So you see here all the fat graft. So always you do a post-op contrast MRI so that with the fat suppression images, so you can differentiate if there's any residual tumor. And this patient had a small residue in the right cavernous sinus situation for radiosurgery. Thank you very much.
Good morning, everyone. A very good presentation indeed. As you said, ENT surgeons we are more familiar with this corridor because of JNE, juvenile nasopharyngeal endofibroma. This tumor spreads this way, so we are more familiar with this approach, and it was a good demonstration indeed. And one thing I have a doubt regarding your post-op radiotherapy. Actually, for journal nasopharyngeal endofibroma, we have a lot of speculation about subjecting the patient for a post-operative radiotherapy, particularly in an end patient. Like the previous speaker was talking about that. For a child, you actually subject them to radiotherapy. But what we think about is because of the long periods of exposure and the long age for the patient, they might have a malignant transformation later on or a second malignancy might occur. So this is a point of concern about post-operative radiotherapy in a young child. I don't know what about your concern about that or your experience regarding that.
So the conventional radiation techniques actually are accurate, but now we have conformal radiation therapies which are available, which are more precise like a surgical blade. So we need not, our amount of radiation which is spilled over to the adjacent sectors, that limits the limit of radiation. Now we have good conformal techniques, and more importantly now we have proton, which is very like what you said. This is one of the indications for the young children where we can limit the radiation to where we want. The risk of second malignancies are not very less with these advanced techniques.
Thank you, sir. And also, I had the chance of working with neurosurgery department once I completed my M.S.C. And that time I had seen a lot of brain edema following open procedures. I think your endoscopic procedures will be far better for any neurosurgery. So I feel because I had witnessed a lot of open surgeries also when I had been working in the neurosurgery department. Right in 2004 or 5, I don't know, 2004. And I had seen a lot of brain edema and the brain swelling post-operatively, all those complications that come across. I think this, with the endoscopic approaches, they are minimal complications.
Absolutely. There's a paradigm shift of skull-based surgery from extensive skull-based microscopic approaches to more and more of endoscopic approaches. So now we have bilateral technique, we have good technical advances. So it's matter that these techniques are more and more young neurosurgeons learn these techniques so that I think in next few years endoscope will almost replace majority of these skull-based patients.
Thank you, sir. And Madam wants to say something. The product. Excellent sharing of your knowledge by all the three speakers, Dr. Vazhthu, Professor Dr. Shanthhi, and Dr. Felicitation. And at this lecture, I want to appreciate efforts carried by Dr. M.Kodeeswaran and his team for organizing this CME Cadaver workshop. And we, the Department of Anatomy, Kilpauk Medical College, is very much pleased and proud enough to contribute the material to revamp your surgical skill to a deeper aspect. I hope this Cadaver workshop will reach its goal. Wish you all the best. Thank you.
Now the question time. Participants want to ask any question? Can ask.
Good morning, everyone. I'm Dr. Ashwin from Chennai Medical College. I have a few questions. First to Prabhashkar sir. You did an excellent demonstration, sir. When we are dealing with huge cellular, supracellular tumors, the moment we enter into the nose, we know it starts bleeding. Even if we have hypotensive anesthesia with a low heart rate, still there is a lot of bleeding. And especially the clival regions, when we leave behind bits of mucosa, it bleeds even after tumor resection. During the reconstruction, there is some sort of oozing. How do you manage this part? Just a practical question.
So I was telling about designing the external approach. Okay, so we exactly know where the blood vessels are. So never touch the turbinates. So if you touch the turbinates, you do a mucosal injury, this is going to bleed throughout the surgery. So tissue handling is very important. So pre-operatively, I told that we shouldn't, when we are packing, we should take care that the pack is, when we are using instruments to use for the pack, we should never touch any of the turbinates. Turbinates are the source of bleeding, arteries are the source of bleeding. If you don't touch these two structures, then most of the times your field is very, very free, right? So then you were saying about the clival disc. The clival disc is full of veins. It's actually the clival plexus of vein. So it is very usual that it will bleed, but venous bleeds are always manageable. They stop by themselves. You just need to put a pack there, wait for 2 seconds, it will come. It will stop. There was one more part of your question which for the supracellular you were saying. Clival disease usually bleeds once you remove the so how I manage it is that I don't remove the clival mucosa until it is 100% necessary. So I don't remove the clival mucosa until unless I reach for that approach. So until that time I keep it very clean. So even if I have a video in which you will see that even there is blood, the sphenoid mucosa removes the blood like escalator mechanism. It continuously pushes the blood away. So it keeps your field very clean, the mucosa. So don't remove the mucosa until unless you are onto the clivus. During elevation of the nerve, plane is very important. If you are in the subperitoneal plane, it will not be. If you are not in the subperitoneal plane, it will be. And you should always have an approximate idea on where the septal artery is there. So the septal artery, you should know exactly this place the septal artery. Then approximately you can make a mark and go a little bit above and go a little bit below. Okay? Just mark the pedicle. Everything else you can practice the that much.
That was an excellent presentation about supracellular extension of tumors. I wanted to know cellular pituitary, okay, straightforward. Supracellular extensions. When do you undertake a transplanar tubercular approach for supracellular extension of pancreatic tumors?
For tumors like adenomas which are having supracellular extension, we always remove the tuberculum bone. We don't put the dura. Dura we open the last as per the need. But the tuberculum bone has to be removed for all supracellular tumors, for pituitary tumors, for craniopharyngioma, for meningioma, all. So, and regarding the bleeding which you asked, I think Dr. Shankar has already covered most of the things. But one practical kind of tip, if I can give, the bleeding from the venous legs between the two leaves of the dura, they are the most troublesome when you are going transtuberculum where there is anterior intercavernous sinus, or in the clival area where you have the basilar sinus and the posterior intercavernous sinus. The mistake which most of the beginners do is when you start opening, it starts bleeding. You focus on putting some surgical gel foam or cottonoid, something like that. Actually, when you open partly, it will bleed. And whatever you do, it will keep bleeding. The only way to stop bleeding is you open fully. This is similar to the scalp in surgical anatomy to stop, that the bleeding stops when it retracts. But when you open partly, it cannot retract. So it will keep bleeding. So whatever you do, it will keep bleeding. So don't focus on hemostasis, cut the leaf fully so that it will retract. Once it retracts, means it will stop invariably. All the venous bleeding, you need to allow it to retract. But arterial bleeding, if it retracts, it will go away from your view, it will still keep bleeding. But venous bleeding, it will stop. So that is one thing which we have learned, and it is quite recorded for scalp injury. So sometimes scalp injury, when it bleeds, you open fully, it will retract and it will stop bleeding. And the second part of the question,
Adam, why does we anyway cauterize the superior intercavernous sinus? We cauterize the dura.
No, means see, whatever you cauterize, if you open partly, it will bleed only. You cannot see, it is like a sinus. Sinus, if it is large, you cannot cauterize. You will have to cut it full and full, means full thickness, and once it retracts, it will stop bleeding. You don't have to do anything. You just keep something till, see, basically you should avoid blood loss. So by keep putting some gauze piece or some cottonoid, it will stop once it retracts.
One more question is that is there any imaging grade or during the surgery, is there any grading for supracellular extensions to decide to go transplant?
See, as I think Dr. Rupesh clearly pointed out, that we have to use navigation whenever the tumor is complex, and in navigation you can extrapolate from what point you will be able to reach what. For most soft tumors, you don't need to go around the tumor because you do internal decompression, the tumor falls. But all complex tumors, which are very close to the vessels or which are fibrous, and meningiomas, you have to always think that they will be fibrous, they will be hard. Never go with the kind of mindset that it will be soft. If the tumor you anticipate it to be firm and then it is soft, it will be a sweet surprise. But a surgeon should never be in a rude shock. Think that it is soft and it is firm. Complex tumors, you should be able to go around the tumor. If you cannot expose in such a way to go around the tumor, then it is risky because you do internal decompression, firm tumor, you can't do much, then you'll have to abandon the procedure. So if you cannot go around, that means your bony exposure should be in such a way that you go around the tumor. So depending upon the location, I think like transpterygoid, transtuberculum, and you have to plan with navigation with preoperative CT scans so that you should never kind of struggle. It should be comfortable. If the surgeon is comfortable, the surgery can be smooth. But if you struggle in the beginning part, then it can be a disaster.
You had a very good talk about third ventricular extinction. If we leave behind some tumor in the region of third ventricle by chance, and you see that in the post-operative MRI, when do you decide to go back?
Like in the last talk by Dr. Rupesh, he had clearly repeatedly pointed out the focus is to remove the tumor away from brainstem. Again and again he was pointing it out. Because you cannot give a good radiation dose when it is stuck to the brainstem. The same thing is applicable for optic pathway. The same thing is applicable for thalamus, midbrain, for every neural structure. So for any surgery, we try to remove the tumor close to the optic pathway and the neural structures. The things which are in cavernous sinus and things which are in the clival recess and all those things, we can do with most of the radiation will cover. But third ventricle, optic pathway, brainstem areas which are close, that you have to struggle to take out the tumor, or if the tumor is very firm, at least can mobilize them little bit away so that you can give radiation to the tumor without damaging the neural structure.
One more question to Rupesh. So it was an excellent presentation on transclival tumors. You were dissecting off the brainstem, basilar artery, vertebral artery. We all know the importance. We all know about vasoconstriction and all this. So, what is the protocol for monitoring, intraoperative monitoring, while doing this transclival approach?
Neuro monitoring?
Neuro monitoring.
Neuro monitoring is not much useful for, you can use for cadaver services now, but here you are using your earlier if visualizing. See, the major advantage of endoscopy is that you are seeing it. Conventionally, what we are using microscopy. In microscopy, you have to go beyond the nerves, and then you put your suction involuntarily you will be causing a lot of effect. So that is not the case here. So endoscopy or hand on it, and you can dissect it. So the real goal of intraoperative neuromonitoring is not much fun. Compared to what microscopy. Microscopy is all about player would say, but endoscopy not that easy.
So there is a lot of dissection going on around the brainstem. So obviously we all know that bradycardia and all these things will happen. So
here what you showed is that the medulla. So for medulla, vector medulla, but we know that because we are all the tumor at the medulla space. If something is there, first brainstem under the tumor, second they want. But here we are just focusing on the tumor approach, then you reach. So the neuromonitoring is really cannot take much. Of course, it's microscope. Vessel dissection is more, especially more respiratory, of course, easy to handle. They have to calculate. You should be much more careful with the calculator because they are the more difficult and you may ignorantly you can sacrifice it. The same applies to the meningeal episode, the superior hypophyseal artery. So those calculators are more difficult to manage rather than the major.
This is to Kilpauk, sir. The trans-territorial approach is it necessary to strip the anti-earth point, post-earth point, sinus mucosa, or it's not necessarily the maximizing substance can be open and can go there. How often you will strip the ethmoid as well as
the trans-territorial approach is for a completely inferior approach. So I had shown for lateral approaches what are things and for what. Ethmoids is primarily for the back of orbit. Back of orbit and orbit apex. For trans-territorial approach, we did not need to touch any of the ethmoids. Even the middle turbinate, probably I will not touch. So primarily, one more thing what we are doing for trans-territorial approach is that we are transposing the pterygopalatine contents into the infraturbinate fossa. So with the adaptar and the inferior turbinate, we take this and rotate it towards the infratemporal fossa, get all the pterygoid in front of you. Pterygoid is at a much lower plane than ethmoids. So we don't need to do anterior post ethmoidectomy for trans-territorial.
neurosurgeons created, so that we should work together. We can do much more things, complex things we are doing that. And the principles are different. Each of the components deliver plan is what is the time see you know exactly what is what you are teaching what you want. That planning is very, very important to very important to if identity and try to work with them grow useful in the long run. So the execution, depreciation, everything is important. Very, very important. Think about it.
I also share what Dr. Rupeshwar was feeling, that teamwork is always better. We can learn from each other, and in the long run, it will be good for the patient as well as for yourself. And another point Dr. Arun said was telling, do not convey the message that that anything can be operated. Don't make it appear as if it is all easy. So I really want to convey. Actually, that is very important. So that's why I think none of the speakers, Dr. Kilpauk, Dr. Rupesh or me, we don't want to convey the message that you can just go in and remove any tumor blindly. Like if I can go Tirukural, Anjuvadu Anjamai Vedamai, isn't it? So we should have little bit of restraint and fear, and but we have to have a calculated, we have to have a plan. I think it was pointed out by Dr. Kilpauk. You cannot just go in and then start thinking what to do. We have to have a full-fledged plan. There are many things which can happen inadvertently, but without plan, we should never go in.
Thank you, sir. Any more questions? Now I would like to request our Professor Kodeeswaran, sir, to kindly honor Sushila ma'am, Tamilnadu Medical Council representative.
Madam Sushila is today here as the observer. So we got 2 credit hours for this workshop. Thank you, madam. So it was a wonderful session. We had a very good discussion today. So now we can proceed to dissection. So we have 6 stations in the anatomy dissection hall. We have 12 faculties. Each station will have 5 delegates and few observers also will be there. I call upon Professor Raghavendran, Professor N.J. Arunkumar sir, Dr. Rupesh Kumar, Dr. Kandapani Shanmugam, Dr. K.V. Karthikeyan, Dr. S.S. Arvind to proceed to dissection hall. So each neurosurgeon will have one station, and I request ENT surgeons Dr. Durga Shankar, Dr. Ganapati sir, Dr. Tamilnadu, Dr. Chandramoli sir, Dr. Ashwin sir, Dr. Anupama will proceed to dissection hall. We will take ground floor anatomy hall. They will help you in dissection. This dissection will be monitored in a LED panel, so you can visualize the main station, and other stations also will have complete support. So all delegates can proceed to dissection hall. I request Dr. Amma Jodi, Dr. Jacob Grant sir, Dr. Nitin sir, Dr. Murugan sir, Dr. Bharat sir, Dr. Suresh sir, they will be the chairperson for this session. Breakfast and coffee will be available in the veranda. If anyone wants to have, they can have the veranda.
We take time. We'll go and we'll go now, sir. We can proceed.